Diathermy. This is a picture of what a diathermy unit looks like. Very common if you ever see one as far as the setup. However, it's not utilized very often, and so you might not really ever see one in any of your clinicals. But let's discuss a case study and try to see if we would apply diathermy as we learn about it. While competing in the monster dash, Gabe fell in the mud and dislocated and fractured his proximal humerus. Now, a year later, he lacks full external rotation and flexion. He still has 3 pins in his humerus. Hannah decides that the best modality to utilize prior to stretching would be short-wave pulse diathermy. Do we agree? Why or why not? So let's learn about diathermy. The prefix dia means through, and the suffix therm is heat, so it's a therapeutic modality that uses high-frequency electromagnetic waves to heat deep tissues. There's, in general, has been 3 types of therapeutic diathermy. Long wave is 1 megahertz. It's the oldest method, but it's not used anymore. Short wave is a wave identical to shortwave radio at 27.12 megahertz. This is the most commonly used waveform of diathermy in orthopedic medicine. And then there is the microwave, which is 2450 megahertz, similar to radar. It's seldom used in the United States, and partly because there are so many contraindications with shortwave or with microwave diathermy. For example, there's hot spots can be created by sweat that accumulates, so you have to keep that all wiped off. If there's any metal in the area, that'll be preferentially heated, so you have to make sure you have a room with no metal in it. So just lots of things to be concerned about and makes it more tedious to use. Shortwave diathermy can be either continuous or it can be pulsed. Now, most treatments are with pulsed wave diathermy because the heat doesn't accumulate and become so intense. So I don't know that I've even ever seen a continuous shortwave diathermy unit. The applicators are these, and this top part here is what we call a drum. Most of the shortwave diathermy applicator is the induction drum electrode type. So this is considered an electrode, even though it looks very different than what we're used to in E-stim. The drum electrode is made up of 1 or more copper coils that are rigidly fixed inside this hard plastic housing. There's 2 types of drums or applicators. If you have 1 applicator, then we call that a monode. And if you have 2 applicators or 2 of these drums, it's called a diplode. And in both of those, again, is that single copper electrode wiring. How does post-wave diathermy work? It runs on a 110-volt electricity from the wall outlet. A generator converts the AC electricity to a radio frequency, which is usually 27.12 megahertz. The radio frequency passes through an inductive drum, which we've seen the picture of. As the high-frequency electrical energy is applied to the coil, a fluctuating magnetic field is generated around that coil. So now we have this field of magnetic energy that we can put a tissue or body part in. As the radio frequency exits the drum, an oscillating field is produced in the body. So this drum sits down really close to the body, almost touching it. As the magnetic field passes through the tissue, it causes reactions in the tissue that produce thermal and mechanical effects, which are positive towards healing. There's 2 ways that diathermy heats tissue. There's one called the dipole reaction and then eddy currents. So the dipole reaction is when we have a dipole which has a molecule that the ends carry opposite charges. So when we put them in this magnetic field, they begin to rotate. The rotation then causes friction to occur in the body, and then that produces heat. So that's the dipole reaction. And then the other one is eddy currents, and the magnetic field will generate small circular electric fields in the area, causing eddy currents in the tissue. These fields then vibrate and increase the cell membrane permeability, which causes heat. When we're using diathermy, we'll have energy distribution and heating effects that will vary depending on the tissue. So the greatest heat effects occur in tissue that has the highest conductivity. So that would be muscle and blood. So because heat is created by tissue resistance, and the greatest resistance would be in muscle. So if we put diathermy here, the skin or where there's fat is not going to have much resistance, so we don't have heat production, but we do have a lot of heat in the muscle and then not much in the bone. That's why you can apply diathermy and the skin will not feel hot, but the patient may say that deeper it feels like it's pretty warm. The physiological effects of diathermy are very similar to those that we talked about with heat. So we have an increase in blood flow, metabolism, fibroblastic activity, collagen deposition, new capillary growth, white blood cell infiltration, so general effects towards healing. Also, it can decrease pain and muscle spasm. So when we used pulse wave short diathermy, these are indications. Remember, though, that none of these conditions should be acute. So we could use it on a strain that's been worth maybe 10 plus days out, but not an acute strain. Same with contusions, bursitis, sprains, tendinosis, any pain, joint stiffness, osteoarthritis, decreased range of motion, or to increase extensibility of collagen fibers. As far as contraindications, there's more contraindications with diathermy than any other modality. So you might say, well, let's just use ultrasound because we don't have to deal with the contraindications. Well, if you have a large area that you need to heat, the ultrasound becomes very tedious and you end up overusing it. So it's a good modality, but used in the right timing. So let's go to the contraindications. When tissue temperature rise is not indicated, so an acute condition. Ischemic areas, anesthetic areas, so they can't feel the area, so they don't know if it's getting hot. Effusion, eyes or around contact lenses, testes, ovaries, cautious during over the pelvis during pregnancy, over moist wound dressings because the moist dressing will actually preferentially heat, and that'll get hotter than the surrounding areas. If the patient has a fever, epilepsy, cancer, a pacemaker, we wouldn't want to do it over a pacemaker, or metal implants. However, you can use diathermy if you just want a mild or moderately low heating around metal if the watts of the diathermy unit that they're producing is less than 48 watts. So what's the difference between ultrasound and pulse shortwave diathermy? Well, both can heat tissues 3 to 5 centimeters at greater than 40 degrees Celsius. Ultrasound, however, heats a small area, and diathermy is a large area. Therefore, with ultrasound, we typically have a short stretch window of about 5 to 10 minutes, and with diathermy, our stretch window is greater, so it could be closer to 10 to 20 minutes. I just want to make a note, too, that in your book, I think there's a table, it's 15.2, that has the recommended parameters for diathermy. You don't need to memorize these, but just know that it's a good reference if you would ever need to set this up and you don't have the operator's manual. Why would we not use diathermy beyond contraindications? Well, partly because it's really expensive. You can find small units from around $5,000 all the way up to a regular commercial unit, $25,000. So a lot of money. There's not a lot of evidence-based research, so there's lots of speculation as to what conditions we should use it on. Is it really the best tool of our modalities? And then the changes in equipment often make it difficult to research. So if they do a research on a particular diathermy unit at a particular watts, by the time it gets published, there may be a different kind of diathermy unit out there, or you can't even find the one that we used in the studies. So it makes it a little more difficult to be consistent. Let's go back to our case study. So we have Gabe, who is now a year later lacking range of motion in his shoulder. He's got 3 pins in it. So in regards to what did we learn about diathermy and should we use this? Well, we know that this is a large area. that has some significant decrease in range of motion. So we would want to increase tissue elasticity, decrease viscosity of joint fluid. This seems to be indicated at this point by looking at that diathermy would be a great option, certainly better than ultrasound, where you would have to ultrasound several different locations to get any response for tissue increasing the extensibility. However, the issue with the pins. So if you still have pins in there, metals in general contraindicated. However, if we're using a pulsed shortwave diathermy and we're not letting it go above 48 watts for some mild to moderate heating, then he should be fine. So I would go ahead and use diathermy. Just cautiously watching in case he said that it got painful, and that would probably be because if the pins were getting too warm. But in this case, it'd be a good thing to perhaps try.